All right, we'll start with the palpation portion of the lung exam. First thing you want to look at is the trachea. One, you've already looked to see if it's midline during the inspection, but now we can press from the lateral side of the trachea over one direction, then the other direction. You're just looking to see if there's resistance that is asymmetrical from left to right. The next portion of palpation is tactile fremitus. You're trying to feel the vibration of her voice through her lung tissue into your hands. So make sure you hit all the lung fields, starting at the apex of the lungs, which starts above the clavicles. And we will ask her to say 99 every time I contact her with my hands. So go ahead with this. 99.
99. 99.
Now when we hit the lower and lateral lung fields, we're going to flip our hands over so the palms are facing down. Again.
99. 99. 99.
Okay. Now you're going to repeat this on the back side, so if you could just spin on the table for me. Same story, apex of the lungs first, so you're going to hit above the spinous scapula.
99. 99. 99. 99. 99. 99. 99.
The last component of the palpation portion will be thoracic expansion. All we're looking for here is to see that both sides of the chest expand at the same rate and equally. So we're going to go to T10. Give a little bit of skin slack. So put your fingers an inch or so out from the spine, then push in so you get a little skin wrinkle, and then your hands follow the contour of the ribs and ask her to do a complete inhalation. Watching the hands come out symmetrically. If they don't, it's indicative of some problem. It could be a number of things, but you would just annotate they're asymmetrical and you continue your exam. All right, now for the percussion portion of the lung exam. We have diaphragmatic excursion that we'll do, and we'll have to percuss all the lung fields, listening for the resonance in those fields. Let's start with the percussion of the lung fields. Same spots as we did with the fremitus are the ones we do for percussion. Now that we're listening for a resonance note, we want to put the patient in a position that is most advantageous to us. For these posterior lung fields, if the shoulder blades are in the way, you're going to get a junky percussion note. So we're going to have her hug yourself in the front, just bring your arms forward, a little forward with the shoulders more, there you go, and lean forward a smidge. Good. Now we've got a great canvas to check out our percussive note. 2 fingers and a thumb. Now you're going to go to the opposite side in the same spot, and you're comparing the two. Next spot, and then the analogous spot on the other side. You continue that way through the posterior lung fields. Now arms overhead. Now we'll hit the lateral lung fields. And then to the front. So go ahead and spin for me on the table. You're not going to have your patient spin on the table like this. This is for your camera benefit though. Okay, same story. You want to prep the surface for the percussion, so you're going to roll your shoulders back and sit up straight. Above the clavicle for our first percussion. Other side. And you want your fingers as flat as they can be to the surface, or else your percussion note is terrible. Go ahead and pull breast to the side. Just cover yourself and to the side. There you go. Now as your arms come up again, we're going to go underneath. And that last lateral lung field. Great job. Okay, the second component for the percussion is going to be diaphragmatic excursion. We're going to need to have access to the patient's lower back. So I can tuck this in like so. Get this little guy out of the way too. Okay. So you're going to start around T10 again and lean forward from your smidge. That's good. Okay, so we're going to percuss from the diaphragm down. And you're going to see how far the diaphragm moves during a complete breath cycle. So in exhalation, the diaphragm is going to be at its highest point. During full inhalation, it'll be at its lowest point. So we can start with a full inhalation, which is, don't do it yet, which is going to drive the diaphragm down as low as it'll go. So just paraspinally, start high around T10, and you're going to percuss down until you hear a dullness. Because as the diaphragm comes down, it's going to pull the lungs with it, maintaining your resonant note. And then as soon as you hit this big slab of muscle, it'll be a dull note. So that's what you're looking for. So go ahead and do a full inhalation and hold. Make sure you're fast enough so that your patient doesn't pass out. Okay, there's my dull note. Go ahead and breathe. Just make sure you let them breathe once you don't need them to hold it anymore. Draw a line. Figures I would not have a pen with me to draw a line. Okay, so I draw a line here. It's right next to, looks like west on that compass. Go ahead and do a full exhalation. Start at that point. Now we're going to come up. It should be dull until we find our resonant point, which is right there. Go ahead and breathe. Now I measure between those 2 points. That is the length of diaphragmatic excursion this patient has. We do the same thing repeated on the other side. I'll spare you, but the same procedure. Full breath in, diaphragm goes low, resonant note all the way down into your first dull note, which is where the diaphragm is. Then the full exhalation, start at your low line and come up. It should be dull until you find the lungs again. That's your first resonant note, and measure that distance. Okay. Okay, the last component of the lung exam is going to be the auscultation portion. You're going to hit all the same sites that you did for percussion. You're just going to do it now with the stethoscope. So make sure your diaphragm is the one that's activated on your stethoscope. Tap, you hear it, it's activated. So same position for you, shoulders rolled back. And every time I place a stethoscope on you, you take a full inhalation and exhalation through your mouth. The reason we're going through the mouth is so you don't get any whistles through the nose. Now I'm going to roll the shirt up to get to the lower lung fields. Okay, spin for me. Same story on the back. Apex first. And make sure you're going at a pace that it's not going to make your patient hyperventilate. Arms in front of you. You can cross them, yeah. Arms overhead. Okay, go ahead and relax. Okay, now we'll do vocal resonance. So vocal resonance is a confirmatory test that you would do. Say you found a problem with your percussion. It sounded like you had a duller percussion note. Or during the auscultation you found rattles or wheezes or pathological sounds, whatever they may be. Or during fremitus you felt one region more than another had excessive vibration that came in through your hands. So it's indicative of some sort of problem going on within the lung region. So say she had a problem right here with all of those things. Dull percussion note, she had increased fremitus, and it sounded funky when I auscultated. So now I'm going to confirm that with the vocal resonance sounds. There's 3 of them. We have egophony, bronchophony, and whisper pectoriliquy. With egophony, I'm going to ask her to say E. It should sound like E. If it sounds like A, that's indicative of a problem. Then I'm going to have her do whisper pectoriliquy, where she says 99, a little whisper of 99. I should barely be able to hear it. It's okay if you don't hear it. If you hear it a little bit, it's okay. If you hear 99 clearly, that's indicative of a problem. And then we had egophony, bronchophony, whisper pectoriliquy. So I didn't say bronchophony yet. Bronchophony is going to be her saying 99 at normal volume. It should sound like 99 at normal volume. If you hear it quite loud, that is the indicator for a problem. So that would look like so. This is our site of problem. Could you say 99 for me?
99.
Okay. Could you whisper 99 for me? 99. Now can you say E?
E.
Okay. And that's that, folks.